global HIV epidemic, we start now to see a growing number of adolescents living with HIV, mainly residing in sub-Saharan Africa. And most of these are perinatally infected children who now reach the age of adolescence. They're considered a particularly vulnerable group, with HIV as the second leading cause of death among this age group worldwide, and programs reporting worse outcomes on antiretroviral therapy. So the adolescent health issue reached the international agenda, and also MSF identified the need to set focus on this specific age group in their programs. We conducted our study in rural Shiratsulu, Malawi, where MSF supports a large decentralized HIV program with ART provision since 2001. And currently, about 34,000 people receive treatment in this project. And the important information is that the majority are virologically suppressed, which highlights the overall success of treatment provision in this project. However, we had very little information available on treatment outcomes and challenges faced by the 1,700 adolescents in this project. So in our study, we aimed to have a closer look at treatment outcomes and reasons for virological failure in this age group in order to guide programmatic interventions. Our specific objectives were to determine the levels of virological failure, drug resistance, and treatment adherence, which was addressed in a cross-sectional assessment, and also to identify factors that shape adolescents' adherence to treatment by exploring individual, social, as well as programmatic contexts, which was addressed in a qualitative study. We start with a cross-sectional assessment. Patients were eligible if aged 10 to 19 years and receiving a first-line regimen since at least 6 months. Among 1,200 eligible, we aimed to include 400. And the main study assessments were viral load from plasma, which is the gold standard measure for response to treatment. If viral load is above 1,000 copies per milliliter, this is considered virological failure or suspicion of treatment failure. In this case, we performed a genotypic drug resistance test, as well as a follow-up viral load test after counseling. We also assessed ARV drug concentration in hair and plasma as a marker of adherence to treatment. We included 409 participants with a median age of 13 years, and as you can see, the majority were on ART since childhood. The most frequent first-line regimen was twice per day AZT 3TC nevirapine, and a smaller proportion received a once per day regimen of TDF 3TC efavirenz. The majority of participants were in overall good clinical and immunological condition. However, the viral load test identifies that nearly 1/3 were currently in virological failure, so basically not responding to treatment. These were referred to a programmatic enhanced adherence counseling, and we performed another viral load test after counseling. And strikingly, still 86% were in virological failure. So to better understand the underlying reasons, we performed a drug resistance test. And the following graph shows for you the resistance data organized by the most common first-line regimen prescribed. As you can see on the left, patients who received the most frequent first-line regimen lost 2 of their drugs to resistance, 3TC and nevirapine, and 36% also lost AZT to resistance. The scenario was quite similar for the second most frequent regimen. 50% had resistance to TDF, 65% resistance to 3TC, and most lost efavirenz to resistance. So taken together, 84% of virological failures were on a completely ineffective regimen, or practically speaking on a monodrug therapy. So they required all fast-track switch to a second-line regimen. Importantly, first-line patients under programmatic conditions don't have access usually to drug resistance testing. If they present with persistent high viral load, they are usually switched blindly to a standard second-line regimen. If we use the drug resistance data, we can predict that encouragingly this blind switch would still work for the majority, with 92% who would receive at least 2 effective drugs. There's a small proportion, however, who would be effectively on a protease inhibitor monotherapy. So in summary, we found high virological failure rates among adolescents in an HIV program that has overall good success in terms of virological suppression among adults. Nearly 1/3 of adolescents were on a failing treatment. And the high prevalence of drug resistance that we found indicates that adherence to treatment is a major problem, which probably already started in early childhood. We are currently waiting for the ARV drug concentration data, which will give us information on recent adherence on our participants, Programmatically speaking, one of the key interventions will be to assure early and frequent viral load testing in adolescents, but also in children, in order to identify as quickly as possible non-response to treatment and prevent accumulation of drug resistance. I'm passing to Rose for the qualitative.
For the qualitative study, we explored individual and social influences on adherence through in-depth interviews with adolescents who are from the cross-sectional assessment, their caregivers, community members, and health workers. We also held group discussions using participatory tools with adolescents on treatment and their peers, and we had 99 participants in total. Observational data was also collected in clinics and community events, and we audio recorded, transcribed verbatim, and translated the interviews and group discussions. We then coded the data inductively, followed by thematic analysis. Our findings showed adolescents' adherence was shaped by multiple spheres of influence: the health services they attended, their family and caretakers, and their peers in the community in which they lived. So I'll present a selection of key results for each of these. Overall, we found adolescents had excellent knowledge on HIV and even on ART. They wanted to take their drugs every day and understood the importance for their health. However, a multitude of psychosocial issues affected their well-being and their resilience. Good treatment literacy was therefore not sufficient for good adherence. What this means programmatically is we need to support adolescent patients in terms of life skills, their capacity to self-manage ART, and we need to improve services for psychosocial issues. Inside health services, staff not only focused heavily on treatment literacy, but they also promoted at times unnecessarily strict instructions about the timing of doses and the food intake needed to take ART. Patients could give up if they were 15 minutes late for a dose, given they were told this was enough to cause treatment failure. Some clinic approaches were also considered punitive by patients, for example, pill count and longer waiting times that were given when clinic instructions were not being followed. Therefore, staff attitudes undermined adolescents' engagement with care. For example, in group discussions, adolescents drew a doctor, seen here, and they described this doctor as fat, frowning, grumpy, and wearing expensive sunglasses. One adolescent boy explained, "Other doctors are better off, but the kind we've drawn are those that cannot manage to stay for 10 minutes while explaining to them about your problems. They would even shout at you for delaying them." So inside health services, we need to review the treatment messages that we're giving patients and also improve patient-provider relationships. In adolescents' families, we found caretaking arrangements were often precarious. In the context of orphanhood and poverty, children were sometimes without a primary caretaker who could support their treatment. Mother-to-child transmission influenced their adherence in specific ways. They were told to hide pills as at risk disclosing their parents' status to household members, and blame and guilt surrounded their infection. Given HIV was a shameful topic and rarely discussed inside families, adolescents were often not fully disclosed as to their status, or their disclosure was incomplete, or it was experienced as a one-off event. In this context, adherence was difficult. Interventions here should consider that adherence happens outside clinics, it happens in homes and families, and we need to strengthen the disclosure process that health workers undertake with children. Adolescents face significant stigma in their communities. It was not possible to take pills in front of peers, and they often skipped doses when they're outside the house. We also found young people had quite rigid roles and low status in their communities. They could be punished for non-conformity, for example, with community expectations around sexual behaviour, and this silenced them. As a result, adolescents who are living with HIV often hid difficulties that they faced in their day-to-day life, as well as difficulties in taking their treatment. They were fearful to seek help from adults in their community and often quite isolated in their experience growing up with HIV. In working with communities, we should consider models that can empower adolescents and reduce their social isolation. So to summarise, we found that adolescents wanted to adhere to their treatment, but they faced challenges in health services, their families and their communities. Therefore, we need a comprehensive approach that can address these multiple layers that influence adolescents' adherence. As a consequence of findings from these two studies, a new program is being developed in Tirad Zulu tailored to adolescents' needs. This program will include early and frequent viral load testing and fast-track regimen change. It will include multidisciplinary clinics that are outside of school hours and provide a one-stop shop, including nutrition and sexual and reproductive health. And it will include psychosocial support for adolescents, including peer clubs that build life skills, disclosure support, and mental health services. We would like to thank everyone who's involved in the study. Thank you.